Thank you so much. So now we're going to go from one extreme to sort of the next. We're going to focus on women who present during their childbearing years and what is sort of the latest information we have right now about the impact of inflammation on pregnancy and the impact of medications on babies. So why does this even matter? Why is this a topic that a lot of people want to know about and obviously are anxious about managing women with IBD during these reproductive years, because sort of the peak onset of IBD and the epidemiology of IBD overlaps when women are in their prime childbearing potential or reproductive health. So this is sort of, this overlap really lends itself to us understanding that if 50% of our patients are women and this disease is happening in individuals during this very important phase, that we need to learn how to optimize the management of these patients. So we also know that it's probably one of the disease states that we know the least amount about, both as physicians or caregivers as well as patients themselves. And really the number one reason why we are having to have this special conversation about pregnancy and IBD is because just informing patients and empowering them with knowledge could make the difference between them deciding they want to have children compared to voluntarily deciding they do not want to have children. The main reason why they decide not to have children is because they're afraid of passing down the disease to their children, the effects of inflammation on their disease, inflammation on pregnancy, or the effect of pregnancy on their disease. And also, of course, the number one reason is the fear of safety of medications on the development of their baby. And we know that if we can increase their Crohn's and colitis pregnancy knowledge, which is the CCPK no questionnaire that was developed, you can actually reduce voluntary childlessness by up to almost 3/4. That's a huge distinction from just not being able to communicate with our patients and them finding the information, unfortunately, on the web. So what are the big misconceptions? Obviously, as I noted, medications are harmful to my baby. I really could be sick. I don't care if I'm sick, if I need to take steroids. I don't care if I'm having a lot of inflammation as long as my baby is fine. Not understanding that the biggest risk to any fetus has nothing to do with the medications, but entirely tied to inflammation. Starting from the ability to get pregnant and the effect of inflammation on ovarian reserve, to staying pregnant and the effect of TNF and IL-23 cytokines on actually something called placentation, which is the development of the placenta. And the rising rates of preeclampsia, both in IBD and non-IBD women, is due to age, but as well as increased inflammation in our IBD patients. So trying to explain that the most important time to actually be uninflamed is in the first 16 weeks of pregnancy does help you also say that for our biologics, for example, the drug doesn't even see the placenta or cross the placenta until way in the 20s. So when the baby is being developed, which is in the first 10 weeks, after 10 weeks, organogenesis has occurred. By that time, the mom's just figuring out that she is pregnant a lot of the times and that the development has already occurred. So we're really not dealing with issues of impact on development. And what you need to keep them on the medication is because the risk of uncontrolled disease. And not only in the first trimester is it about preeclampsia and having the right implantation of the embryo to create the placenta in the uterine wall, but staying pregnant and having the baby grow normally during the second trimester. And in the third trimester, it's about keeping them uninflamed, because there's now evidence to support that inflammation in the third trimester actually impacts cognitive development of the child and behavioral problems with ADHD, anxiety, and behavioral issues in toddlers. So there's like a really big reason why I could end the talk right now and just say to you that you need to tell these moms that the most important thing is that they are in a remitted and controlled state. And the fact that other than our small molecules, which do cross in the first trimester, for example, tofacitinib or thiopurines, it's because we focus on the use of biologics during the first trimesters because they don't even see the fetus. So this is a very important distinction to really sort of take down a lot of the anxieties and the fears around managing pregnancy with the medications we have. So if you first want to go back and say, all right, so the misconception is that I may not even be able to get pregnant. That is a huge question that I see. I run a IPAA clinic, which is Preconception and Pregnancy Planning, where we see and we try to get women, and John Fred is wonderful at sending me these women who want to get pregnant and they just want to hear what is it about their meds and how do I keep my disease under control and what do I need to do with the timing of my medication. So the timing is really to see these women before they get pregnant, because then you could sort of lay the stage that your OB is going to tell you you're going to stop this medication, you're not going to stop this medication, and you sort of walk them through the importance and get them to the high-risk OB team, hopefully, pretty quickly, because they actually know that what's more important is the mother. Because if the mother is good, the baby will be good, which is completely opposite to most of the general OBs, which is focused on the baby, and if the baby's good, the mother will be happy, right? This is a very important distinction that I'm making. So fertility-wise, if you had to make a blanket statement about fertility, what we could say is that outside of, for what we know from retrospective bad database studies, we have nothing prospective to say for sure, but our retrospective studies say that the only thing that really impacts fertility is a woman that has undergone an ileal pouch anal anastomosis, the actual act of resecting or dissecting the pelvis, the rectum, taking the ileum and forming the J pouch, for example. That is where infertility happens. It has been shown that in the era of open surgeries, you actually decrease the rate of fertility or increase the rate of infertility threefold, from about 15% to 45% in women who've undergone an open, which means not laparoscopic, because the data is all in the open era, that when you go in and there's the surgeon's hands dissecting and stapling down in the pelvis in the absence of a laparoscope, the infertility rate goes up to close to 47%. We are currently developing a prospective fertility registry for all women who've undergone a J pouch in the era of laparoscopic, so I hope that we'll have an answer to show that the rate of infertility is nowhere near 45% and probably closer to general population in the era of laparoscopic surgery. So hopefully we'll get that answer shortly. However, their most serious complications really are tied to inflamed disease, as I noted. So you look at low birth weight, preterm birth, flaring, miscarriage, and stillbirth. This is what we need to focus when we're discussing with mothers or potential mothers, is that we care most about the inflammation, and that is where we are going to focus. So if it means that you've been walking around with active disease and you've been afraid to start a biologic because you want to get pregnant, as an example, we're going to actually say, well, we're going to start you on a biologic so we can get you pregnant. That sort of discombobulates them a lot because they can't sort of put those two and two together, and that's when we get into the importance of inflammatory control. Now, we did not create a guideline, but we created sort of a care pathway for the management of women with inflammatory bowel disease through collaboration of the Crohn's and Colitis Foundation. Our industry partners, particularly UCB, was very involved, as well as the AGA. And this really purpose was to give you all the information that we're sort of talking about today, but in a reference guide so that you feel confident about how we're approaching the management of women. And we also have a parenthood group that is basically for patients. So there's a piece there that matches what we say clinically to what the patients as a resource can go and feel more confident about our decisions. This just goes back to what I said before, that there is no known congenital malformation risk with just having IBD itself. By the way, that was looked at a long time ago. Jason Dominance, actually at the VA in 2006, sort of started to explore this possible relationship between having an inflammatory condition and malformations. That was never found. And then earlier on, 5-ASAs, steroids, and thiopurines probably as an ancient historical categorization of category D, which scared everybody, and that was based on animal data. And then human data said that you can continue thiopurines during pregnancy, and that's where we land today, that the major congenital anomaly rates are no different between women who are not on thiopurines and women who are on thiopurines. So we are continuing that if that is the therapy for that patient. This slide is very sobering because it does show you who is stopping drugs in our patients, in our derm patients, in our rheum patients, and you could see that the primary care physicians and the general OBs are proposing stopping drugs more than keeping them on drugs, which means that there is a huge expertise gap here. This is a big problem because women come to you confused. And it's your job to sort of demystify a lot of this, and by coming to a conference like this, it gives you the education, the information, say, I saw this talk, I now want to, talk more about what I understand to be inflammation control is my goal for you, and less about the safety of meds. And you could see that gastros are number one at not stopping meds. So I think we feel there's a bigger price to flaring. There's a bigger price. We don't want to operate during pregnancy, for example. So maybe psoriasis, you could put a topical cream, or you could see it. So we get a little bit more sort of attentive to the idea that we want to prevent flares, bowel obstructions, and want to really make sure we know what our patient has before we recommend them even getting pregnant. The bigger problem is when they come to you pregnant, flaring off meds because their OB told them to stop everything. That's a bigger issue that we deal with on a regular basis. So what is the fear, or where did this all come from? Well, it's mainly, I'm going to talk about biologics when it comes to placental transfer, because there is an FC receptor, which is at the bottom of our antibodies, meaning almost all of our biologics, with the exception of certolizumab, which, if you remember, is a pegylated, does not have the FC portion, therefore does not attach to the placenta, why there is no crossing of certolizumab across the placenta at any real time during pregnancy, and that's because of the structure of the molecule, not the target. This is an important distinction. So if you take all of our other biologics, they all have an FC receptor that likes to attach itself to the placenta, and this sort of transfer across, and the FC receptor gets upregulated as you get closer to the weeks sort of 20 and beyond, particularly in the last trimesters where you see this really preferential transfer. Remember, the placenta cannot differentiate immune globulins that women give their babies for protection against infection. It looks the same. It's an IgG subclass 1. The placenta doesn't know that this is infliximab, as an example. It just thinks, oh, I'm going to give this baby the immunity that the mom has, and crosses over. So that's why it's preferential in the third trimester, and you can imagine that babies who are born prematurely do not get even the protective immune globulins that they would get, and that's why we worry more about infections in these babies that are premature, who haven't been quite exposed to even maternal protection. So this is what started the whole drama in 2006. Gil and I were at an institution that started this. I'm one of the authors on the paper that discussed that we had a baby who definitely had higher levels of infliximab in their bloodstream than the mom even did. And for the purpose of science, she stopped breastfeeding, thinking, as we all did, that it must have been the breast milk. And then she said, forget this, I want to breastfeed my child. And she continued to breastfeed, and the drug levels went down despite breastfeeding. So that's how we knew that it was placental transfer. And that actually led to some label changes. So there was a lot that came out of that knowledge about knowing that these drugs do pass. So this is a study in Europe because, again, there was this sort of European or cross-Atlantic discussion or debate about, do you stop the drug early because the drugs do cross? Do you stop it before the placental transfer starts to occur, meaning you'll stop the drug in like week 22, 24 weeks of gestation, which leaves 4 months of a mom who needed a biologic to even get pregnant to now be off of a therapy, and probably we were thinking flares would increase. So we had, I'll show you the next slide that definitely shows that. This is just showing you over time per trimester how many less people were still on a biologic as they move through pregnancy. And you could see that you start off with good intentions. 80% of moms were still on in their first, then you reduce down to almost 50% in the second, and then you could see a third of women are still on their biologic in the third. This is based on a European cohort. And this same cohort, which we were very excited about, did say is that I know we in Europe were telling you to stop it early. We've now seen that when we stop it, moms flare. So it looks to be that given the low risk to the baby in terms of infections, mom may have had, if they continued it after 24 weeks, there was some intra-hospital infections that we need to dig into. We're actually going to present at ACG. There's an oral from one of my medicine residents looking at C-section and vaginal tear healing by getting a TNF or a biologic literally the day you deliver to show whether or not it impacts wound healing. There is no impact on wound healing from any of our therapies. And so this was just, we're digging into what are some of the infections maybe that they may have seen in the hospital, but the babies were not impacted by getting biologic or TNF after week 24, which is great, and the moms were flaring. So it kind of came out that we need to continue therapy beyond week 24, that it really wasn't that problematic to continue. So we're starting to see a creep-in effect of continuing the drug. So this is another story. This was a model that was developed by the Amsterdam group, which actually showed that indeed infliximab, much more than adalimumab, does increase in the third trimester. And it's about a twofold increased rate of placental transfer of infliximab compared to adalimumab, for reasons I can't explain. And so this is showing you that around week 30 and above, you start to see really a separation that infliximab starts to cross. So just keep that in mind, and this actually replicates a study that was done by the group in Calgary, Cynthia Sau, who actually showed that adalimumab levels dropped in the moms in the third trimester, but infliximab levels went up, which spoke to the fact that you can probably minimize your last dose of infliximab closer to week 30, and you don't have to necessarily keep giving it repeatedly in someone who's on every 8 weeks. It doesn't mean that if she needs to get it, she won't. It just means maybe your timing may change. A lot of people confuse what I'm saying by, I'm not telling you to stop the drug. I'm just telling you you may be able to give it a little earlier than you normally would to get it as close to week 32 as possible to minimize exposure in the cord blood. Good news is no matter what the drug level was, there was no increased rate of infection to the babies. So that was a very positive outcome that they looked at, that even in the face of having good drug concentrations in the baby, in the cord blood, it did not translate to infection risk in the baby. And our piano study has similarly showed that, by the way, that no matter when the moms got their last dose, the baby's levels did not correlate with infectious complications. This was a nice paper in Gastro a couple years ago that looked at the timing of when a woman got her last infusion to see that it correlated with lower cord blood levels. And it looked like if you gave the last infusion around week 30 rather than week 32, I'm just giving you an example, that the baby had lower cord blood levels at the time of delivery. Now the slide I just showed you said it didn't really matter what the cord blood levels are, but you know, you could still be cautious. So if you don't need to and the REMI levels go up or infliximab levels go up anyways, and it's better to give the last infusion around week 30, therefore it gives you a time point that you should be aiming for. In my own practice, once they tell me they're pregnant, I sort of change around the timing of the infusions so they're getting their last infusion at week 30. Unless they're hanging on and get it every 4 weeks, I can't really quite do that much somersaults to get them their last infusion. This is again highlighting that infliximab, this is what we looked at, the cord blood to maternal blood ratio. And it shows if you take infliximab, a 2.4 ratio means there is 2.4 times more infliximab in the cord blood at delivery than the mom at the same time at the time of delivery in her serum. And you could see for adalimumab and ustekinumab it's about 1.4, so just slightly above what the mom had. The good news is for vedolizumab it's less than 1, which means the mom has more than the baby, which speaks to the fact that maybe there's a different transfer of the FC receptor for transfer. And certolizumab, this was also reaffirmed in the CRIB study, which was a sponsor-initiated study confirming that there is no cord blood levels of certolizumab, which really speaks to the fact that it does not cross. I'm just going to quickly skim through vedolizumab, for example. We don't have a lot of data like we do with the TNFs in terms of exposure, just to be transparent. Based on small numbers and based on our own experience, all of us have given vedolizumab during pregnancy, and thankfully to date we have not seen any adverse outcomes. At this point, there was some rumblings at ECHO that there was a group that gave some vedolizumab and there was some adverse events in the baby. We've not seen that. Ustekinumab as well does not look like congenital malformations and or infections and or miscarriages or any other outcome is different between controls if the mom got ustekinumab. One thing to remember that ustekinumab is the only biologic that was tested in a primate placenta. Why is that relevant? Because the primate placenta is the closest placenta to human placenta. All the other biologics were tested in mice. The mouse placenta is nowhere near looking like the human placenta. And I could tell you that the baby chimps, poor things, did not have any toxicity despite how high they went up on the dose for the animal toxicity of ustekinumab in the moms, chimpanzees. But that's the point, is that even with the good animal tox, we did not have increased toxicity. TOFA remains on the table. Does anyone have a woman in the room who they've intentionally used tofacitinib in the first trimester of pregnancy? I was debating. I haven't quite made the leap. Most of the women don't want to be the first. So when I say, well, you could be the first, I sell it like that. They're like, I don't want to be the first, of course. So there's been a couple across the country where we've added TOFA once development has occurred after week 10, just to give you a perspective on the congenitals. I think we just need more data on this. So again, we will start to see women feeling better, getting pregnant, coming to us, declaring themselves having gotten pregnant on tofacitinib. That's what I think is how it's going to be. So we'll see. And anyone who has anybody, please email me because we want to start to collect the data. The other thing about vaccine responses, that's something we worry about, is do the babies mount a response even if they've been exposed to any of our biologics? The answer is that the babies do mount a response. It may not be some of them as high as a baby not exposed to any of them, but within our IBD patients, the vaccine responses look appropriate. This is where this biologic and sort of childhood development, I do have another slide in a bigger deck that I use, which actually where they looked at cognitive development. This was in piano. We looked at whether or not any of the babies long-term had any cognitive or developmental delay if they were exposed to any of our biologics. Not to say that biologics make you smarter or anything, but the point is that control of inflammation is all that matters. I get back to that sort of undercurrent that if you control the inflammation, then the baby's environment, the amniotic fluid, the cytokines and the vasculature will be improved. And remember, the gyri, something is happening to the brain in the third trimester. That's where all the neuroplasticity is occurring, which is why there's a suggestion that having chronic inflammation impacts cognitive development. Breastfeeding, we know we say is safe for the drugs that we have. In the biologic story, we've actually looked at, and even if it's nanogram levels, it's too big to cross the GI tract of the baby, so we continue to breastfeed. Everyone should have the app LactMed on their phone. If they don't, LACTMED, and that will give you drug levels that will tell you if it could be used in pregnancy, if it could be, in breastfeeding, and will even tell you the latest data as of yesterday, because one of our colleagues, Jason, who's out of Scripps, actually updates it daily. So anything that comes out in the literature, you will have it. So LACT and then MED. Monitoring during pregnancy, again, working with your high-risk OB team, they'll help tell you with regards to imaging. We all don't like to scope, we don't like to operate, all the things that we don't like to do, but flex SIGs during pregnancy we've done. We've had actually a couple of unfortunate recent colectomies in the second trimester. UMA as well had one recently. And also that shows you the CRP could be elevated for pregnancy. SED rate is always up with pregnancy, don't follow that. That will be up in all women. Their hemoglobin will be down and their albumin will be in the 2s. That is normal for pregnancy. All the labs that we search for activity also go down in will change in pregnancy. Calprotectin, there was a more recent publication that showed that it does differentiate active from inactive. So a way to monitor your moms may be also to use calprotectin during pregnancy. In terms of endoscopy, obviously, do you really need to confirm that a woman with colitis is having rectal bleeding and diarrhea, that you need a scope to confirm that they have activity? Probably not, unless there's something new or a newly diagnosed, and of course ruling out C. diff. Perform in the hospital with MFM and limit your procedure time. Postpartum care, just is a very big area of controversy. This is what I will state. What we do know is vaginal delivery is absolutely contraindicated with active perianal Crohn's. That's an easy one. Then the debate is the relative contraindication. A woman with a past history of horrible perianal disease, do you really want to have a grade 3 or 4 tear which actually rips into your sphincter and therefore leads to incontinence? Do you want someone who has a J pouch to have a grade 3 to 4 tear, ruin their sphincter function, end up with permanent ostomies, incontinence? So you need to think clearly and work with your surgeons and work with your high-risk OBs. You will get a lot of pushback from general OBs about C-section. They're trying to reduce the elective C-sections. But you take a strong stance with your women. These are not women who don't need continence, right? No woman needs incontinence, I'm not saying, but I'm saying that in essence, these are people who need a very durable sphincter. Don't forget about venothrombotic risk in IBD, that women with IBD are already at increased risk of VTE, and then you add pregnancy. So at the time of delivery, work with your high-risk OBs or your OBs to ensure that they are anticoagulated. We forget this a lot. And how can we guide our patients? Patients want to talk to you about safety of meds. Patients want to know how their disease will impact their baby. Please, when you are starting a new medicine, tell these young women, and those of you who manage pediatrics, tell the moms that we know that these drugs do not, the ones you're going to be using, not methotrexate, not thalidomide, I'm not talking about that, the drugs you're prescribing, the great news about it is we have a lot of data during pregnancy, and therefore this is a drug that will not impact their fertility. This is what the moms want to know, so start disclosing, and to any young woman who's starting on a medication. So, take-home message, poor knowledge leads to voluntary childlessness. Post-pouch associated with infertility is the only thing we do know, and that's in the era of open surgeries. Decide on the timing of biologics. For now, if the mom needs it, she gets it. If the mom flares, please treat. No live virus vaccines for the first 6 months if moms were exposed to any of our meds, with the exception of certolizumab. And the only one that would refer to is rotavirus, because that is the only live vaccine given before 6 months. Measles, mumps, rubella, and varicella are given at a year, so safe. And in New York, this impacted us because we actually were needing to give MMR in the Orthodox Jewish community to kids at 6 months. So we had to delay some of our moms who got exposure to the biologics for the babies to get it just after 6 months, and sometimes we were actually checking the drug levels of the meds in the baby. So this did impact us a lot with regards to measles. And medications are safe during pregnancy and breastfeeding, and just remember that control of inflammation is king. So queen, king, queen. I'm in any royalty. So thank you so much for your attention.